For those of you that have joined us today in person, thank you so much for making the journey in. I'd also like to thank those of you who are joining tonight virtually, including the clinicians in Ballarat, Albury and Tasmania. So for those who don't know me, I'm Daniela Samela and I'm from Stelligens Greer, and I'm joined this evening by my Victorian counterpart, Catherine McHale. We're also joined this evening by our country manager, Rachel Sutherland, and our medical director, Dr. Martin Rees. We would also like to express our gratitude to both Professor Joe Douglas and Associate Professor Kymble Spriggs, our esteemed speakers this evening, as well as to Dr. Samantha Chan, who will be chairing this evening's meeting. Before I formally introduce Dr. Samantha Chan, I would like to take a moment to introduce Stelligens Greer as a company and its commitment to evidence-based quality allergen immunotherapy treatments for your patients. So with a century of experience in treating allergies, Stelligens Greer stands at the forefront of allergen immunotherapy. Each year we provide treatments to over 1.6 million patients, demonstrating our commitment to improving lives globally. Driven by innovation, we do reinvest 20% of our annual turnover into R&D, and this includes the annual Stelligens Greer Foundation Science Awards for allergy and ensures we continue to lead the way in effective allergy solutions. Stelligens Greer is committed to ensuring quality use of medicines, which we know is very important, through rigorous quality assurance in all our processes. We do utilise the Reliable Standard Index of Reactivity, so the IR, which most of you are familiar with, measures of biological potency, and ensures high quality allergen extracts with batch-to-batch consistency. The allergen extracts are cultivated at our manufacturing facility in France, which includes the temperate grass pollens, including ryegrass in Orale and the house dust mites in Actair. Our products are supported by product-specific clinical evidence, which does include the double-blind placebo-controlled trials, the real-world evidence, observational studies, and biomarkers. Actair, Orale and our bee venom immunotherapy have been independently assessed for quality, safety and efficacy in Australia and have obtained TGA approval. This means these products are available for either the same or next day pickup at your patient's local pharmacy. Alternatively, you as clinicians can order directly via DHL and receive delivery within only a couple of days. Finally, I'd like to highlight the importance of prioritising ongoing monitoring of quality, safety and efficacy of products, and we do this through our pharmacovigilance monitoring. So for patients across Australia whose quality of lives are impacted by allergic rhinitis, we do recognise the vital role you as clinicians play in delivering accurate diagnosis and effective treatments. Your dedication ensures that your patients receive the care they need for improved outcomes and long-term management for the condition. For those of you here in person, we have included a notepad and a pen on your table, so please feel free to take notes. If you have any questions, can you please write them down and give them to either myself, Martin, Rachel or Catherine, and we'll pass these on to Samantha for the Q&A part of the meeting. There is also a meeting questionnaire, and we would kindly ask that you complete these with your feedback on tonight's meeting, as it is crucial that we continue to provide the best experience for you moving forward. I would now like to introduce Dr. Samantha Chan. Dr. Samantha is chairing this meeting. She is an immunology and allergy specialist at the Royal Melbourne Hospital and is the Victorian State Representative for ASCIA. Samantha is active in research and is completing her PhD studies under the supervision of Professor Douglas, contributing to some of the key research that will be featured in today's meeting. Please join me in welcoming Dr. Samantha Chan.
Yes, perfect. No, you're all good. All good? Yeah, I reckon so. Thank you. Thanks, Daniela, for the introduction. I'd like to start out by acknowledging the traditional owners of the land where we meet tonight, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present, and all the First Nations people continuing to live and share knowledge on this land. Thank you very much to Stalligens for putting together a fantastic dinner. It's wonderful to see so many people all in the same room together, and I think that really speaks to the importance of the topic that's being covered tonight, as well as the excellent presenters that we have lined up, who I think are probably well known to many people in the room, but I'll introduce them anyway. So first off, we'll have Professor Joe Douglas, AO, who is the James Stewart Professor of Medicine for Melbourne Uni Medical School, as well as being the Head of Research for the Royal Melbourne Hospital. She's a prolific mentor, clinician, academic researcher with over 100 original publications and a particular focus on allergic asthma and thunderstorm asthma. Kymble Spriggs is an Associate Clinical Professor at the University of Melbourne. He currently leads the Department of Clinical Immunology and Allergy at the Royal Melbourne Hospital and is also the lead for the State Venom Immunotherapy Centre at Monash. So an exceptional teacher and researcher across many different facets of allergy. It'd be great tonight if you could try and write your questions down or hold them in your head, because I'll try not to pause in between the two speakers because there's a lot to cover tonight. If you have something burning, you can try popping your hand up. We'll try to move through as efficiently as we can, so save it for the end if you can. And with that, I'll pass over to Prof Douglas.
Thanks, Sam, for such a kind introduction, and thanks also for the opportunity to talk to you all tonight. It's really always great to meet colleagues and to have opportunities to talk about something we spend so much of our time doing, and hopefully we can continue to learn to do it better. So I want to talk about advances in allergy biomarkers, in particular thinking of respiratory allergy as a treatable trait and options and that implications for targeted therapy. I do have a number of declarations and they're attached. And just to give you an overview of what I want to talk about is the key drivers of respiratory allergy in Melbourne, and talk about then allergy biomarkers, both of disease and tolerance, so we can think about how we might frame up our diagnosis and treatment in perhaps a more evidence-based way, because at the moment most of our immunotherapy is opinion rather than is based on our opinion rather than perhaps facts. Rather than biomarkers. If we had biomarkers, we'd do a lot better. So, into that, let's talk about key drivers of respiratory allergy in Melbourne. This is a picture on the x-axis of the year, and if you think about after the summer's peak and throughout the year we have dust mite. Those of us who see a lot of allergy patients think that dust mite often peaks a bit in the autumn months, but it's a year-round allergen and certainly has been associated with asthma and asthma symptoms very significantly in many studies. Peak 2 is the grass pollen allergy season, which is definitely changing. In the time that we've been monitoring it and watching the Melbourne Pollen app, it used to be it started in the 1st of October and there was almost no grass pollen around. The last 3 years there's been grass pollen at the 1st of October, so it's definitely changed and is changing. The season seems to be lasting just as long, in that grass pollen is detectable in pollen counts until the end around Christmas time, with a peak usually in November. And it's interestingly that most thunderstorm asthma events have happened in the 3rd week of November till now. So we do have some understanding of that. Of course, the grass pollen season is preceded by the tree pollen season and followed by the weed season. So often in January, February, you get weeds, and in particular plantain. And those of you who grew up in Sydney or have trained in Sydney will know people pay a great deal of attention to it. There's just as much plantain in Melbourne, but we ignore it. So it's an interesting discussion about what that really means for respiratory allergies, but I'll leave that for you to think about. So if we think about respiratory allergies in Melbourne, this is a paper from Jeremy Silver, which he published looking at 25 years of aggregate data of emergency asthma presentations and averaging them over the year. And this is the all-age group picture, which looks at the peak of asthma presentations occurring in February, March, which if you break this down into ages, which I would like to do there, the early peak is generally individuals younger than 24. So this is the children peak, and we all recognise it's viruses when kids go back to school. Then there's a winter peak, which is in those over 25 and up beyond 65, the older age group, which is obviously respiratory viruses over winter, and particularly influenza. And then we have this springtime peak, which associates with the grass pollen season and is really not observed in the over 60 age group. It's seen in the 0 to 65 year age group. And that is really important because these asthma-related presentations seem to occur in the younger age groups in the springtime. Why am I saying it? Well, we all know about thunderstorm asthma, but what I'd like to suggest to you is that there's actually a seasonal surge of asthma presentations, which is at least double that of the baseline rate, which occurs in springtime. And the most likely trigger for that is grass pollen allergy. So whilst we can notice thunderstorm asthma events and we can think they're really important, there is actually a seasonal surge that we ought to be considering in terms of its burden to individuals as well. So combined with this, there's actually quite a lot of allergic disease that will be driving disease allergies in Melbourne. And in particular, the key drivers of respiratory allergy in Melbourne, if you look, this is from the Melbourne Pollen app today from Ed Lampugani, who pointed out that today, for the first time, pollen counts were coming up into the extreme range, which is usually over 30, and I'll give you some quantitative data on this later in the talk. But interestingly, because it was a fairly warm night, we had high pollen counts overnight, which is unusual. But the other thing you'll notice about this is its continual counting, because up until very recently, we've only had over a 24-hour aggregate counting through Burkhardt spore traps on a single slide. But there is actually live pollen counting available now, which can allow 24-hour monitoring. We've only got one of them, and it's in Parkville at the moment. But it's an opportunity to really look not only at pollens, but also moulds, which are clearly part of the story and we don't look at, and also other particulates. And it can also actually look at allergen levels in the allergen component levels in the biomass. So I think that will likely improve greatly our capacity to diagnose and understand what is going on in respiratory allergies. So I want to talk to you today about some allergy biomarkers and recent research and publications in that, and in particular those that you might use as indicators for considering allergen immunotherapy or for allergy intervention, both in related to thunderstorm asthma and also markers of efficacy of immunotherapy. But one of the first things I want to say as an allergist is that allergic rhinitis is not predictive of thunderstorm asthma hospitalisation. And this is some data from Mark Hugh and Frank Tian, who published in Allergy from the 2019 event. And our data in TASAR confirms this. So what Mark did was look at, on phone survey, all individuals who presented to emergency departments with on the 2016 thunderstorm asthma event, as many as they could recruit, which was 1,400. And they, at that time, took a history of severity of rhinitis using the ARIA questionnaire, with 0 being mild. Moderate is ARIA classification 1 to 3, and severe ARIA classification 4. And what they showed was there was no distinction between those who had severe allergic rhinitis and who ended up being admitted to hospital and those who were discharged home. And this is very clear also in our data from TASAR. So severity of rhinitis does not correlate with likelihood of presentation or severe asthma. I think that's an important feature to take away, at least not in both of these two studies. So if we don't think that rhinitis is a marker for associated asthma, could we also then think about blood biomarkers of asthma? And in particular, this is a study that was led by Philip Lachapelle and Nurse Sharan that looked at individuals who were admitted to the Royal Melbourne Hospital in after the 2016 event, those who were hospitalised and those who were not hospitalised, and looked at those. 51 went to ED only and 19 were admitted to hospital. And you can see there's a trend. It was not significant to higher levels of ryegrass pollen-specific IgE in those who were admitted to hospital versus those who were discharged. And so the question then arises, can we... is blood-specific IgE a potential biomarker for severity of asthma as a complication of allergic rhinitis. It was suggested by this study but not proven, and it'd be good to look at that further. And so as part of that, we undertook the TASER study, and I can see Christine McDonald and Phil Barden, who were partners in that study, very much so, looking at identifying risk for thunderstorm asthma in severe allergic rhinitis. And we recruited a cohort over the 2018 pollen season. We looked for people who had allergic rhinitis and those with thunderstorm asthma, and we collected questionnaire, physiological and data about their symptoms going forward, also prospective data. And I'm hoping, well, I'm not sure about this, these slides aren't quite as I thought them, giving the prospective data, looking at that over the year. And we followed them with the Aerator app prospectively. And so we had biomarkers at presentation, and then we were able to look retrospectively at their reports of whether or not they had thunderstorm asthma or allergic rhinitis. And in particular, the group who had seasonal allergic rhinitis only had the lowest ryegrass-specific IgE. The group that were discharged from hospital had a higher ryegrass-specific IgE, and the group that were hospitalised for, who actually went to hospital with their thunderstorm asthma. Sorry, this group had stated they had symptoms, but were treated in the community. This group went to hospital, seemed to have a higher ryegrass-specific IgE. And when we looked at all the data, 4 indicators fell out of risk for having asthma in those who had seasonal allergic rhinitis. And they were the level of ryegrass-specific IgE. They were FeNO, exhaled nitric oxide, blood eosinophils, which you might expect as a marker for asthma exacerbations, and lower lung function, still within the normal range, but actually around 90% predicted. And so we looked at these using a ROC curve and looked then at a Uden index, the inflection of the curve as a cut point, and the area under the curve giving us a sensitivity and specificity for predicting thunderstorm asthma in those who had seasonal allergic rhinitis in the TASAR group. And what we're able to show is that blood eosinophils of 0.2 or greater, so still within the normal range. Ryegrass-specific IgE of greater than 10.1 had the best specificity and sensitivity for predicting hospital presentation in those with seasonal allergic rhinitis. The exhaled nitric oxide of 27, now bear in mind that's an intermediate level, it's not 50, which is the indicator of usually clear eosinophilic inflammation, and an FEV1 that was just below 70% using a Z score. So the best of these that in terms of sensitivity and specificity was the ryegrass-specific IgE. So that's a pretty useful marker and it's available broadly. The problem is, of course, that it's retrospective. So we don't know if having been through the season, whether that may have actually increased the threshold. And so it behoves a prospective study. But I'd like to encourage you tonight to consider that thunderstorm asthma is just an event that happens every 5 or 7 years. We're kind of due one, but who knows with climate change. But it is the tip of the iceberg, if you like, for thunderstorm asthma morbidity. But in fact, ryegrass pollen-induced asthma is a major annual event which does cause a seasonal burden to our emergency rooms and is likely due to ryegrass allergy or substantially associated with seasonal allergic rhinitis and ryegrass allergy. And that we've now got not only symptomatic burdens, I've mentioned that rhinitis is not a good risk predictor for asthma in the setting of seasonal allergic rhinitis, but low lung function could be. High pollen counts might be, and the blood biomarkers that we've got are ryegrass-specific IgE, and I want to present a little bit of data about the allergen components, LOL-P1 and LOL-P5. So, I just wanted to present to you, I said that TASAR not only looked retrospectively at patients describing thunderstorm asthma, but the individuals also had an app called Aerator, so they could log their symptoms going forward over the 2018 grass pollen season. And we could look at their occurrence of grass pollen exposure and rhinitis symptoms over the ensuing 3 months. So this would be one of the very rare times we've actually correlated in a live way symptoms with pollen exposure. And what we did was we were able to geolocate the individuals and get grass pollen counts at the time of reporting their symptoms. And we were able to, we classified them for the purposes of this into grass pollen grains per metre cubed, which at 20, 35 and 50. Just so you know, 50 is considered extreme, 30 is very high by the usual markers. And they also looked not only on the day of exposure, which you'd of course expect, but we also looked at lag days. What happens at day 0, if day is the day they report? What happens at day 1, 2 and 3 afterwards? Because we had some evidence from other studies that looked more in meta-analysis that this might be important to how people experience symptoms. And the pattern we observed was that 20 grass pollen grains didn't seem to do much to rhinitis symptoms. At 35 you saw a slight increase, and it was just significant at day 0. But at 50 grains you saw an increase in ryegrass related symptoms, which seemed to persist for a couple of days after the initial exposure. So that is and this, if you can look this on a graph, it gives you a different way of looking at it. If you like, the lag here shows a slight increase in symptoms, but gets worse as the ryegrass pollen counts increased. But the most important increase in symptoms, which was most evident, was at day 0 with the highest ryegrass pollen, what you'd expect. But interestingly, the asthma pattern for similarly looks different. And here we just looked at ryegrass pollen at 50, the very high amounts, and looked at day 0, the day they reported their symptoms, plus day 1, plus day 2, plus day 3. And if you look at this picture, what happens is that their symptoms within the high grass pollen days, it's high at day 0, it's higher by day 3, and that's significant. In other words, there's a lag of asthma symptoms day 3 after a high pollen count day in relation to asthma. And I think that's very important because it does give us time to consider about the opportunities for preventive treatment for asthma, and also to implement whether preventive therapies ought to be implemented. We are just working to see whether it's possible to get meaningful data to split this up by ryegrass-specific IgE, but I'm not sure we have enough data for that. But it's a really novel way of analysing it, and I really owe a debt of thanks to Rachel Tam, Hannah Murray and Prasanth Konduru, who did this statistical modelling. So day 3 post-asthma, post-exposure leads to asthma symptoms. And I just want to put that out there because all of the thunderstorm asthma events, if you go back, they're almost always on day 3 of a high pollen count group. So it's the third day that seems to be associated with asthma. And that might be one of the reasons why thunderstorm asthma epidemics don't happen every time we have a thunderstorm in springtime, because you need that cumulative effect. So we look forward to looking at that a bit further because, as I said, there's a problem with TASER, and that is it looks backward. We need to look forward. And so, again, many of you in the room, several are collaborating with me, collaborating with us on this prospective study called Carista. We're looking to create a risk assessment tool for seasonal allergic and thunderstorm asthma and potentially validate the biomarkers that we've identified in TASER looking forward. And the plan is to recruit 400 individuals with allergic rhinitis and ryegrass pollen sensitisation, to collect the initial demographic data we have, to do lung function and blood tests, and follow them up for 2 years, looking at and using a smartphone app, not only to record symptoms, but also to correlate with air quality, pollen levels, and hopefully other particulate particles, because I still have a great concern. If you go back to the silver paper, thunderstorms and pollen accounts for about 50-60% of the asthma activity in that graph. But there's clearly a third trigger, and we don't know what it is in the springtime, and I'm wondering if it might be moulds, but we don't know that, so I'm very curious. But that would be my hypothesis. So we're looking forward to having the chance to prove it, provided we get the high-quality pollen counts that we need. So where to now? So is allergy, in fact, a treatable trait for airways disease? And ryegrass-specific IgE threshold might be something that we could look at for actually considering treatment of lower respiratory disease in people who present dominantly with allergic rhinitis. Why do I think that's important? Well, as those of us who treat a lot of asthma know, you're not going to give the 1 in 5 people in the community who come in with hay fever asthma treatment. I just don't think that's going to happen. And they're certainly not going to take it in advance of the springtime in a preventive way, which is what we probably need to protect people, in my view, from thunderstorm asthma. So we need to identify a group who actually at higher risk of lower airways disease. So ryegrass-specific IgE threshold might be part of it. Or could allergen component analysis be part of it. So the temperate grasses, as you know, have pollens that are about 20 microns in size, which is why they impact on the upper respiratory tract. But of course the purpose of a pollen is to fertilise a flower, and so it bursts when on exposure to humidity, which might be our eyes, our nose, or of course the stamens of a flower. And it releases these subfragments, which are then released into the air, and these tiny fragments are about 2 microns in size. And in fact, if you look at these, and this is a study that was done a long while ago with the American temperate grass, closely related to ryegrass, Kentucky bluegrass, and showing the intact pollen when inhaled goes to the upper airway. A lot of it was swallowed in this, but none of it went to the lungs. But when they aerosolized these small fragments and labelled them with radioactive, you can see that they went to the lungs in great abundance. I wonder about the ethics for this study, but I guess it was on 73. So a really good illustration. But the other point to remember that the exterior of the pollen grain has group 1 allergens dominantly on it, whereas the interior of the pollen grain has dominantly group 5 allergens. And a lot more people are sensitised to the group 1 allergens than the group 5 allergens. So the intact pollen grains bear group 1 allergens, and the group 5 allergens are related to starch and glycoproteins that are on the interior of the pollen grains. The subtropical grass pollens, like Bermuda, mostly do not contain the group 5 allergens. And the other interesting thing is that Timothy grass has group 1 allergens, has great homology with ryegrass group 1 allergens, but the group 5 allergens on Timothy and rye are very different. So we can't use FIL-P5 as a surrogate for LOL-P5 in this. So what is a major allergen? A major allergen is really something to which more than 50% of the individuals in an allergic community react to. And it's also important on the potency in terms of the size of the skin test, which is a surrogate, I guess, for how much histamine is released on exposure to the allergens. So, of course, component resolved diagnostics is very big in Europe and very big in understanding allergies better. And of course, those who are particularly interested in food allergy, and I know there's a lot of paediatricians in the audience who particularly rely on things like ARA-H2 and the cashew component analysis to give a really good idea of risk of anaphylaxis. So can we think about this in relation to grass pollen allergy and maybe do better in that way? So, this is a study from Fruertes who looked at FIL-P5, the Timothy grass pollen allergy, in a European cohort, and showed that the FIL-P5 levels, the group 5 allergens of Timothy grass, which is of course the common abundant grass in Europe, was more consistently associated with allergic rhinitis symptoms in this panel study of adults. Interestingly, in this study, it wasn't more associated in that with asthma. But if we look at a group, Celia's here from the Alfred, so they did this work. This is from Mark Hughes' group and from Robin O'Hare, who looked at the group 1 and group 5 sensitisation in a sample of patients who had reported thunderstorm asthma, and then a control sample who didn't report thunderstorm asthma following the 2016 epidemic, and looked for their levels of group 1 and group 5 allergen-specific IgE, and looked for differences in this group. And what they showed was that the group 5 allergen was higher, although and significantly so, in the group who had epidemic thunderstorm asthma. The takeaway from this message, though, that was the group 5 allergen sensitisation predicted and was more closely associated with thunderstorm asthma in this group than the LOL-P1 sensitisation. It didn't perform much better than total ryegrass pollen specific IgE. So maybe you wouldn't get much of an advantage by looking for recombinant allergens. But the criticism of this study is it was more of a convenient sample. It wasn't randomised, and there may be better ways of looking at it, and a larger sample might give us more ideas. And so we did the TASAR sample again, so the 228 individuals who we had assayed at the start of the 2018 season, and looked at them with relation to LOL-P1, LOL-P5, and just the antigen saturation, so really a group total grass pollen test. And what we were able to show that there was an increase in the LOL-P5 in those who had thunderstorm asthma symptoms and a hospital visit. And we've done more statistical work on this since, and Janet Davies has particularly been associated with this and showed that in fact there was, so it's very small, but we'll go with it, that LOLP5 sensitisation particularly was more associated with significant, with an odds ratio presenting with thunderstorm asthma to hospital compared to LOLP1. And LOLP1 is, of course, the very abundant allergen and very much the LOL very potent sensitiser, but it's LOLP5 that seems to be associated with asthma, which is what we might think. So it is possible that LOLP5 specific IgE might serve as a better biomarker for allergen-specific for allergen-specific responses related to asthma. And this is something we can explore in the Carista study going forward. So, as you know, so I want to switch tack a little bit. I've been talking a little bit about biomarkers of risk for asthma in those with rhinitis. What about looking for biomarkers of efficacy of allergen immunotherapy? Because you would be aware that we judge efficacy of allergen immunotherapy by clinical art more than clinical science, I would suggest. And whilst the evidence suggests and convention says 3 years, some say 5, but generally consensus says 3 years, and certainly there's fairly good data using oral air tablets and other sublingual tablets for 3 years of seasonal treatment. But this has really been advanced by Robin O'Hare's group at the Alfred, looking at a biomarker for tolerance for induced tolerance for ryegrass-specific IgE related to oral air administration. And what they looked at was IgG2 following 3 years of pre- and post-seasonal sublingual immunotherapy, and looking at cell markers. And what they were able to show was that the IgG2 was increased as a biomarker of efficacy. Now, this is just a slide going back to one of the original slides of oral air showing efficacy from 3 years of treatment and showing durable efficacy beyond cessation of treatment in years 4 and 5, which is what we perhaps would hope and think if we're going to do sublingual immunotherapy. But that particularly got advanced, which looked at the thunderstorm asthma event of 2016, where Robin Hare's group looked at the occurrence of thunderstorm asthma symptoms following the 2018 event and showed that oral air seemed to be quite protective with no symptoms in those who had undergone 3 years of sublingual immunotherapy. So it's some data, and there's not a lot of data that shows grass pollen immunotherapy is effective for asthma, but this is one of the few papers that might suggest that. So it is an important marker if we're going to be thinking of protecting patients from asthma as well as rhinitis in the spring grass pollen season. It's also important to note that group 5 allergens is very important, and it's in the tablets that are in oral air, and that is true. Oral air is a combination of 5 temperate grasses, but generally those more closely allied with, there's certainly ryegrass present and others which have fair homology with the group 5 allergens. And if we look at biomarkers of efficacy, and again this is from Robin O'Hare's group, as you can see IgG4 has often been touted as a marker of allergen immunotherapy, and it does efficacy, and it does increase in 3 years of oral air therapy, but the marker that really increased was IgG2. And allergen-specific IgG2. So whilst this is not a commercially available test, it does offer promise that maybe we will have or could have a marker of allergen immunotherapy efficacy in the future. And it's certainly a holy grail of immunotherapy because we would know then how long we might need to treat for. We'd have a marker of when we needed to retreat, and we could genuinely consider having a more advised way on looking at patients with grass pollen allergy. And similar data has been found with Actair, which is the which is the house dust mite tablet, and looking at 3 years of treatment and showing that IgG2 increased, allergen-specific IgG2 increased more in the responders compared to the non-responders. So there is evidence across allergens that allergen-specific IgG2 could be a biomarker of efficacy. Again, not commercially available, but promise, and that's a very hopeful thing. With regard to Actair, you certainly can get, so that's the perennial use of the house dust mite tablet. You can certainly see efficacy after 1 year with significant reduction of symptoms of around 18% compared to placebo, and that is durable for at least 1 year after stopping the treatment. But we recommend 3 years allergen immunotherapy for optimal duration. But again, a biomarker for tolerance would be very useful. I'm going to finish off just by thanking the many people who've worked hard on the TASER study, many of whom are in this room, and I look forward to continuing working with the group on the Carista study. I think I hand over now to Kymble, is that right?
Yeah, that's you.
Okay, just let me make sure that I know how to drive these slides. Great. So, thank you, Joe, very much for that talk. You've set the scene very well, and you've taught everybody about these different allergens, which we're now going to learn to apply. So I'm going to be talking about key concepts in allergen-specific immunotherapy, evidence and practical application. So, how do we, with all this information we have about allergen-specific immunotherapy, maximise its efficacy? What allergens are the ones most critical to target, and what is the dose that's required to maximise efficacy? And how can we simply and practically apply this with an AIT algorithm or a rule of thumb which can be used in clinical practice? So this is a diagram illustrating the journey that patients have when they come to the clinic to us with allergic rhinitis. And we're looking at change in quality of life on the y-axis here, and the x-axis here is the various stages that occurs over time. So patients have allergy symptoms and they attend for treatment to us. We go through a diagnostic process, then we initiate a therapy, we go through the early results and we consolidate that therapy with the promise of benefits that last after treatment. And today I'm going to focus on the middle section here, and 2 key points: which allergens are most critical to treat, and also what is the dose that's required in order to get this optimal efficacy. So looking at the allergens most critical to treat. So Joe's already introduced you to this graph, this cartoon, this figure, which shows you really the distribution of allergens throughout to the major allergens that people experience, which are both grass pollen and dust mite. And they introduced you to the concept that house dust mite is a year-round allergen, which I'm sure you're aware, with some seasonal fluctuation, but also that we have this big peak in the springtime for grass pollen, which, as Joe has already told you, we're collecting more and more data about how that changes and how that fluctuates. But really, these are the 2 dominant parts that affect our patients in Melbourne. We do have these other smaller peaks of our other allergens, but actually we're really lucky in Melbourne because of our temperate climate, and we're going to talk more about that as we go forward. Now, sensitisation data, the sensitisation of the patients in front of you, how much does that help you sometimes? Because most patients, when you look at those that are coming to the clinic, are sensitised to house dust mite to some extent. And also, a lot of patients are sensitised to temperate grass pollen. Now, that does not necessarily translate into clinically important sensitisations, but it's really widespread, this co-sensitisation. So, what allergen is primarily responsible for driving disease during the worst parts of the year, the seasonal allergy period from October to December? And also, key question number 2, how could common sensitisations that we see on testing in practice arise via cross-reactivity without driving significant disease? Well, Joe's already alluded to this a little bit in terms of the story around prevalence of grasses within Australia. Now, this is a chart looking at temperatures within Australia and talking about the 2 dominant families of grasses that exist: subtropical grasses and temperate grasses. And these are really distributed in a sort of gradient from north to south, well, south to north, based on temperature, where we have the temperate grasses in the more southern regions and the subtropical grasses up north, with a small degree of overlap here as we go up and down. And this is a good prediction, and as you can see in Melbourne here, we're lucky in a sense because temperate grasses are very dominant and they're very pronounced. And this translates into the pollen that we see. So this is an example of pollen distributions both in Brisbane and Sydney. So Sydney is a temperate, a northern, but it's still a temperate zone. And you can see there's this dominant springtime peak, whereas Brisbane in this subtropical zone, it's a more extended peak leading into the subtropical season because it persists being warm there. So these subtropical peaks and subtropical grasses can potentially contribute to these the hay fever situation in the new year. Now, looking specifically at Melbourne data, this is one of my master's students from a few years ago, Lachlan Teggett, and he did a really interesting experiment to try and characterise exactly what's in the air in Melbourne with regard to pollen allergies. And so this is the Burkhardt trap, which is the traditional method of counting pollen that then we use microscopic slides to count the number of pollen grains, as Joe was talking about before, to give us an indication of risk of exposure on a day-to-day basis. But what Lachlan did, he actually used a high volume sampler, which means it was continuously sampling air onto these foam pads here and collecting all the pollen in a 24-hour period, which he then distilled down into these tubes to do a DNA analysis and a pipeline which could really give us information to the level of species that were actually present in the air throughout the pollen season. So these are Melbourne's top 10 grasses from 2016. And as you can see, here you've got ryegrass, which was a quarter of the pollen, and sweet vernal, which was 30% of the pollen based on Lachlan's DNA technique. So by far the majority of these are the temperate grasses. And actually only a tiny proportion here, and these are the ones that are extending out here, the buffel grass, canary grass, and some others were actually subtropical species. And when you split this up, temperate grasses make up 88% of all the available pollen detected over that season in Melbourne. But also, perhaps interestingly, we could look at this on a week-by-week basis. And this is running from July, I think, here down to April. And you can see that over winter, spring, summer and autumn, you can see the traditional spring peak, and this year it was clearly evident from September running through until January. There's still quite significant levels of pollen here. And the green here is these temperate grass species, the species that Joe was talking about before, ryegrass pollen, timothy grass, sweet vernal grass. And the Chlorodidae species, which is Bermuda grass, and Panacoideae, which is Bahia grass, which are our subtropical species, you might even not be able to see the Bermuda grass on the map here because it's these tiny red slices at various points here. And there's more Bahia, which is these orange slices, but you can see they drift into the new year. So really there's very limited levels of subtropical pollen, and really, for the most part, not really any during this peak September to Christmas period. And this is matched by data in Sydney. This is a different group looking at the pollen in Sydney, reproducing the pollen counting in October through to January in these high pollen count days, and then looking at this later peak in sort of the summer going into autumn. And via a different mechanism of analysis, they were able to establish that Lolium and other Poa species, which are the temperate grasses, are by far this early season peak here. And then the Chlorodidae were much later in February, March, matching up with our experience there. And I think it is really important to realise that the subtropical grasses are really never responsible for those peak season symptoms in September through to October. And this is matched by data. This is pollen count data. This is the Melbourne pollen count app and the Canberra pollen count app, which showed that close correlation between the temperate grass pollen counts as recorded with actual patient-reported symptoms via the app. Now, we've already seen this graph that Joe presented, which is Jeremy Silver's work, looking at this peak being driven by temperate grasses, and it can be attributed to grass pollen almost exclusively. And the asthma presentation to hospital is actually lowest in the January area, where subtropical grasses may be considered a meaningful proportion of pollen in the air. Again, you've already seen this slide talking about the differences between temperate grass pollen and subtropical grass pollen, such as Bermuda. The temperate grass pollens containing both the group 1 allergens and the group 5 allergens, which we've already heard are probably very important to asthma and severe rhinitis disease. But the subtropical grass pollen does not have these group 5 allergens. So, if the temperate grass pollen with these group 5 allergens are primarily responsible for this disease, then we've got the answer to our first question. And key question number 2, could some common sensitizations arise via reactivity without driving significant disease? So we'll now look at that question. So firstly, looking at plantain's cross-reactivity to ryegrass. So the group 5 allergens of ryegrass actually have a homologous structure to some of the structures in plantain. And there's actually a cross-reactivity nature here. So some of the skin test reactivity that you may see could be related to cross-reactivity here rather than meaningful clinical sensitization. Similarly, when you look at cross-reactivity of the group 1 allergens of Bermuda grass, the SYN-D1, this has also got a high homology with LOL-P1, which is the group 1 allergen, as these are all basically come from the same superfamily of grasses. And that can explain a lot of the cross-reactivity that we may see in Victoria here, where there's not a lot of Bermuda grass around, and yet we still see that come up on skin tests. So another way of looking at this, which I think is particularly powerful, is when we compare data from the subtropical regions up in Brisbane compared to a temperate region such as Sydney. And this is some work that was done by Janet Davies, PhD student, looking at cross-reactivity and doing a RAS inhibition experiment to try and delineate what was the original sensitization. So what was the main and most homologous sensitization rather than a clinically reacting cross-reactivity. And you can see here that in the serum from the northern regions, or in Brisbane, there was, when it was inhibited with ryegrass pollen, you couldn't actually inhibit out the reactivity to SYN-D1. But in the more temperate regions, you could inhibit it out, suggesting that the original sensitization up north may be subtropical pollens, but definitely in the more temperate regions, this cross-reactivity is perhaps just due to this group 1 allergen homology. So now we've answered both of those key questions, what's going on. So now we can look back at this graph about what are the most critical allergens to target. And I think both from Joe's talk and also the data that I've presented here, you can see that for patients whose most intense symptoms are occurring in this seasonal peak here, that temperate grass pollen is almost definitely the causal allergen. And the group 5 allergens are a major contributor to this, and these are only available in temperate grass allergen exposures. And also that we can see there's a reason why there's polysensitization with these subtropical grasses and why it might be common, but this is not necessarily clinically meaningful. So, changing tack here. Now, what AIT dose provides optimal efficacy? So this is a figure that I did many years ago trying to explain what AIT efficacy is dependent on. And it's dependent on 2 key factors. One is the dose of allergen immunotherapy, and the second is the overall treatment duration. And this is trying to communicate that suboptimal dosing or suboptimal term of dosing may lead to lower potency AIT being received by the patient and therefore less effects. So this is an outcome here that is important for our patients because we want our patients to get the best effects that last going forward into the future. So this is all about dosing. Now, when you're considering AIT options and AIT dosing, it's important that the benefits here are, for the patient, is that we want early, robust benefits that the patients are going to experience and benefits that can be consolidated and project into the future, even after we've ceased allergen immunotherapy. And that's really the special benefit of AIT that we sometimes don't think about with our patients. Now, this is compared to suboptimal treatment, where if we underdose patients, they will not get the full benefit, and these also these benefits may not project into the future. So how do we know the right dose? Well, the main way of finding a dose is a dose-finding study, unsurprisingly, which is a phase 2 trial, which you may have somewhere buried in your brain. And this paper was looking at allergen immunotherapy dose-finding studies and what we're trying to establish here. And these are patterns that you may find when you're trying different doses. So this is a placebo and then 4 different doses, escalating doses, trying to show the efficacy of that. The dose finding that you want to show is a plateau, i.e. you keep giving more dose and you don't get any additional effect. However, if you keep giving more dose and you keep getting more effect, you haven't found the maximal tolerable dose. Now, in house dust mite slit dosing in the 300 IR dust mite tablet, which Allergens makes, unsurprisingly, you can see this plateau in that they went up to from a 100, 300 and 500 IR doses, and they found a plateau of effect and found that the 300 and 500 IR doses had a similar level of efficacy, but the tolerability was much improved on 300. So therefore, we have found an optimized dose for this particular product. Now, there are other sublingual tablets, the 12SQ tablets from ALK and Seqirus, which they've dosed to 3 different levels, and they haven't found the peak. They haven't found the plateau of effect in terms of symptom improvement. And actually, this tablet is marketed at different dosage levels in different countries as they've optimized it based on local regulatory constraints, perhaps rather than patient needs. Now, when we look at subcutaneous immunotherapy dosing, what data do we have here? Well, we have very poor dosing around subcutaneous immunotherapy because phase 2 trials were really not in fashion when subcutaneous immunotherapy was first developed. Subcutaneous immunotherapy, as you're aware, has been around for over 100 years, but really some of the landmark trials in this were done without dose finding on the basis of understood and received wisdom at that time. So the rationale and evidence regarding ideal dosing here is lacking. So, also speaking around dosing, I'd like to bring to your attention a process that's going on in Europe at the moment, especially with the German TAV process. Now, in Germany, they have a wide range of allergen immunotherapy products available, as they're very centrally located in Europe, and there's allergen immunotherapy companies in many of the major states there. Unlike here in Australia, where we have a very limited range of products that are imported. And what they've been doing is they've been trying to establish the data and evidence around these products so that there is dose finding and efficacy data, with the goal of having products on the market that are available which are fewer and better documented, and thinking that perhaps a lot of the products on the market are systematically underdosing patients. So looking at some of the insights from this, although we have a very limited range of products in Australia, some products that are available in Australia, such as the sublingual allergoid tablet and some other injectable allergoid products, have actually been withdrawn or are under a threat of withdrawal in Germany because they haven't been able to establish any evidence to meet those claims. Furthermore, with regard to the risk of suboptimal dosing, this is a real bugbear of mine, which is that of mixing allergens. So mixing allergens, it comes from a good place. People are trying to maximize the effect for patients because they think that covering multiple allergens is going to do the best thing for them. And they think that all things on the skin test are created equally. But as we've already discussed, that skin testing may be just due to cross-reactivity and not really meaningful dominant allergens. And the important thing to take away here is in these subcutaneous preparations where you can actually request a mix, you are not actually adding together the same equivalent doses. You are actually halving, or in fact, doing a third of the dose of the effective dose. So even if you think you may have had an effective product to begin with, you're actually reducing the dose significantly, which really is sort of crazy. Even if you had an established dose, we wouldn't give out 250 milligrams of amoxicillin and then reduce the dose by half and then a third in patients. And this is similarly problematic when you get to the idea of grasses. Because in grasses, you've already seen a lot of data tonight that temperate grasses are by far the dominant and the important allergen to consider in Melbourne. But if we mix in these subtropical grasses, which are really by far not the major problem here, we are systematically underdosing our patients going forward, leading to worse outcomes in the immediate term and also probably reducing the durability in the long term. So, considering AIT options, local guidelines, the Council of Australian Therapeutic Advisory Committee suggests that if patients are indicated for allergen immunotherapy, you should use a TGA-approved product because obviously this has some of the data attached with it. And when we're considering AIT options and evaluating the value to the patient, the registered products that we have available in Australia, they do have not only these oversight mechanisms, but they've got dose-finding studies, they've got documented short-term, long-term improvements, and documented lasting benefits. Now, these are not really available clearly for most of the other unregistered products on the market, or there are big gaps in the data. So this paper is one that I did with Stephen Durham a few years ago, and it's a paper very close to my heart because it's all about communication of the important parts of allergen-specific immunotherapy. And this is a figure that we did based on one of Stephen's collaborators and a meta-analysis, Martin Penegos, which was looking at all the allergen immunotherapy data that we had as to when effects occurred, how long you continued after that in order to try and consolidate effects to give that lasting durability. And so it defined these 3 key phases, which I think we all sort of have a vague idea about, but we don't actually talk about them specifically. So we called them in this paper the early short-term effects of immunotherapy, the consolidation process where people have already got an effect but we're continuing to give them immunotherapy to get these durable benefits, and the lasting long-term benefits. And this graph was deliberately done without any time points on it because this is probably product specific depending on what you're using. But it was thought that it was really important to have this mechanism and structure for communication to communicate to the patient in order to get buy-in and set their expectations so they would continue to participate in therapy in order to get adequate adherence. But I think it's really useful for other practitioners to think about that when they're understanding what they're prescribing, so they can actually have a sensible communication about the outcomes that they're trying to achieve. So when we're considering these ART options, unsurprisingly, the Stelligen's products have both of these well defined because they have a lot of data behind them. So the 300 IR house dust mite tablet, they have an optimized dose around this, and similarly for the grass pollen tablet, it's understood when these early short-term benefits occur, as early as 2 months in the house dust mite tablet and as early as 1 month for grass pollen tablets. And also we have data for these products about when lasting benefits accrue. So there was a house dust mite study, as Joe presented earlier, looking at just 12 months of therapy, giving 12 months of durability after that, even just within this, with one lot of 12 months of therapy. And similarly with Oralair, as few as 18 treatment months, so 3 cycles of 6 months, gives durability after that for 2 whole further years. Now, another thing I'd like to show you is improvements over time in real-world practice. And this sort of speaks to the graph that I showed before, like my graph, where people gain these benefits within the first year. Most patients do, but it does vary by patients. And this is real-world data from Japan looking at rhinitis severity over time. This may look complicated to you, but I think it really illustrates what we see in patients when we treat them adequately with an adequate dose. And you can see here at day 0, before commencing treatment, most patients have either severe or moderate symptoms of rhinitis. And then within 6 months, the reverse is true. Most patients now are asymptomatic or are mild and have accrued significant benefits. And at the 1 year mark, the vast majority are already showing a significant improvement. And this progresses throughout therapy here. But although this I think is really interesting and speaks to this onset of effects, how is there a maximal limit to these effects, which it seems to max out for some of these patients? And this is a recent paper that was a reanalysis of the phase 3 data for Actair, which looked for these maximal effects by disease severity. What it did is it broke apart the original phase 3 trials into tertiles, where it looked at the placebo control group in order to analyse how much background symptoms existed in the community. So, and there's other work which is not presented here to show that there's actually a background rhinitis symptom level that exists within the community in normal patients for the whole year. And unsurprisingly, in those with the higher level of background severe reactivity and symptoms in the placebo group, those had the highest level of improvement against placebo in the analysis. So this shows much better effects in those patients, with almost 40% of patients having an improvement here. So almost double that of the headline phase 3 data that Joe presented before in these most severe patients. And not only that, in these severe patients, this was also sustained for a further year of treatment. Now you might be asking, well, you told us that polysensitized patients didn't probably matter because it was just cross-reactivity, but is there actually data on that? And there is data on that. These are in the phase 3 trials. You can see there's a huge proportion of patients here that are co-sensitized with grass, and they had similar outcome and efficacies in the monosensitized versus the polysensitized patients in the ACT-AIR trials, and also in the oral air trials. It had similar levels of efficacy here in the monosensitized versus the polysensitized. Polysensitization actually having a higher level of treatment effect in these pooled efficacy analyses. And also looking at Australian patients, this is a observational trial that Cheryl Van Noonen did a few years ago, and it actually split patients apart into patients who were monosensitized just to temperate grass pollen, or who were polysensitized to temperate grass pollen and subtropical pollen, and you could see that there was no significant difference. There was improvement in all these groups, but there was no significant difference to those only sensitized on skin testing to the temperate versus the temperate and subtropical grasses, giving you confidence that the subtropical probably isn't relevant in terms of therapy. So again, effectiveness in Australian patients, this is what Joe presented before. This is local data showing this improvements in oral air. And this occurs in this paper with just 4 months of pre-seasonal treatment. So even lower doses still gets these great effects. So what are the key takeaways here? Which we've already sort of talked about, that for patients whose most intense symptoms occur in this early season, patients whose most intense symptoms occur in the hay fever season of October to December classically, they should be optimised to target these group 5 allergens, particularly to temperate grass pollen, and that there's registered treatments which have got good data, both international data and local data, that this is effective and probably provides value for the patients. Also, based on the other things that we discussed before, named patient products involving allergoids, which have no durability data anywhere in the world, and also mixing of allergens where you're not even sure what the dominant allergen is, systematically probably risks underdosing our patients, and therefore them not getting the benefits which we want them to accrue. So finally, I'd like to finish on a practical AIT algorithm, which is a rule of thumb guide for treating allergic rhinitis patients. And really, instead of coming from a sensitization point of view, I come from a pragmatic, practical point of view. We always want to show in allergy, we want to show a relationship between allergic symptoms and exposures. And this is what you can do through this algorithm, because we know when those exposures are going to be for these dominant allergens. So what causes the patient's most intense and troublesome symptoms? Is it a year-round sensitization without any seasonal flare? Or is it a seasonal flare that exists within this October to December period? Or is it another allergen that you have to characterize another way, such as cat or some other direct exposure? And then does another allergen drive the troublesome symptoms? If no, then you're well placed to treat that dominant allergen that you've established based on the symptom exposure nexus. And if there is 2 allergens, you can either start with the most troublesome allergen, or you can target 2 in parallel, or do this serially or sequentially and review progress. But I really think it's, in a sense, for most patients, a lot easier than we think if we take a good history from the patient. If we listen to them and we really probe them about when their symptoms are, you will have a good understanding about what the exposure is and what's likely driving their symptoms. And not to be confused by the skin prick testing, which, as we can see, is just very cross-reactive and potentially complicating the situation. So that's the end of my talk. Thank you very much for your attention.